Karel, thank you very much for the invitation, Dr. Romanelli. News on endoscopic full thickness resection. Okay. So these are my disclosures. 7 seconds. 5, 4, 3, 2, 1. Liftoff. Okay. So endoscopic resection techniques are very successful. Polypectomy, mucosal resection, and ESD, but they are limited to the mucosa and the submucosa, which is probably fine for 99% of all lesions. However, if we have a negative lifting sign, especially if it's scarred or even malignant infiltration, or if we have a difficult location, or even if we have subepithelial tumors, then the conventional endoscopic resection techniques run into problems. And Dr. Crow already mentioned this, that we have this whole new terminology on endoscopic full thickness resection. But basically it comes down if you first make a hole and then close the hole, like the surgeons did for centuries, or if you try to first make a wall duplication, like in stapling, and then resect the lesions. And primary breach would be probably stir, the most advanced technique, and in non-exposure techniques, the closure before resection, EFTR, with the FDRD system. So our approach was always to go for these non-exposure techniques, so close the defect before resection, make a wall duplication either with a clip or with sutures, following the concept of clip, staple first, and cut later. So this is the FDRD system from the Ovesco company. This is the only available full thickness resection system on the market currently, and it follows the principle that you go to the lesion, that you have a transparent hood attached to the end of your endoscope, which is 2.2 centimeters in length and 1.6 centimeters in diameter, at the outer diameter at the end. And then you have a snare inside of this transparent hood and a over-the-scope clip on the outer side of this transparent hood. You go to the lesion, you grasp the lesions with a forceps or with an anchoring device, then you pull it into this transparent hood. And once you pull it into this transparent hood, then you fire your clip, and immediately after firing the clip, you close the snare and then resect it full thickness. This was the first case published in 2014. You see this is a recurrent lesion, an adenoma, already twice resected with EMR technique. No way you can take it out because it's so heavily scarred. You just pull it in, you make the resection, and then you see this peritoneal fat, you see the wall duplication, the resected specimen. The pathologist is very happy because he's get a full thickness resection specimen for evaluation. After some pilot studies, we did a multi-center German study in 8 different centers. 181 patients finally enrolled, published last year. You can see the bulk of indication were adenomas with a negative lifting sign, 60% T1 carcinomas and 8.3%. Nothing we would aim for in the first place. We would aim for T1 carcinomas if we have a patient that's been resected and the pathology says, oh, well, it's probably a low risk, but I cannot tell because the resection margin is in the coagulation zone. Or if I think it's a benign lesion and then you resect it, then secondarily you find out that it's a carcinoma. Adenomas at an appendic orifice, 34 patients, and the 8 in the verticular and 23 subepithelial tumors. The lesions were located all over the colon. 50% actually were on the right side of the colon, so this is a technique not only for the distant colon. How about the results? These are the results in detail, but I think due to time reasons, we just highlight some results. So the technical success rate was overall 89.5%. The R0 resection rate, 76.9%. The procedure times in median 50 minutes. And the only difference, if you go to subgroup analysis, was the size of the lesion. If the size exceeded 2 centimeters, the R0 resection rate dropped from 87% to 58%. But since these are benign lesions, there's no harm with it. You can do like piecemeal on time with these lesions just coming back 8, 12 weeks later and then do a re-resection. Complication rate, severe adverse events were 9%. And we had, so need for surgery was in 10.4%, but most of the patients who required surgery, well, because they were high risk or unsuccessful EFTR, or it was incomplete for these reasons. For real complication, there were only 4 surgical procedures needed, 2 for perforation, 1 to appendicitis, and 1 for enterocolonic fistula. We have a registry in Germany, and there's been over 1,200 procedures performed so far. And this is, we ran the stats on this registry just last week, and we included 1,176 patients, colonic FTRD, and you see the technical success rate exactly the same as in this Resection study in these tertiary referral centers. The full thickness resection, 87 compared to 91%, the same, and also the R0 resection rate, 76%. Complication rates also about in the same ballpark. Need for surgery, 1.9 compared to 2.2%. So I think this shows that this procedure it's technically rather an easy procedure, because these were centers all over Germany started to enroll into this registry just after the training. So good to perform procedure. I want to highlight some special indications. I think a very good indication is full thickness resection for neuroendocrine tumor in the rectum, where you cannot remove it without ESD or some time-consuming procedures, and we included here 40 patients, and you see all of them were removed R0 and 95% full thickness resection, and there was basically no complication except minor bleeding. So for rectal neuroendocrine tumors, I think this is the procedure to go. Another thing is, how should we go if the lesion is too large to be resected with full thickness resection, or even most of the time if you start out with a piecemeal EMR, you think, okay, I'm advancing nicely, but then run into problems because a certain portion of the polyp is non-lifting, and then you don't know what to do. And then you can easily combine it with this, we call it this hybrid EMR full thickness resection, which is you do your piecemeal EMR around the lesions, and then the portion that's non-lifting, you just do an FTRD in the same session. We published this over 20 cases, and we had no major complications rates. So this is, I think, a good procedure. How about the upper GI tract? This was the first patient I encountered in 2015. This was a 42-year-old lady. She had adenoma at the second part of the duodenum, already surgically removed once, and had a recurrent adenoma. So the next stop would have been a Whipple's procedure or a transversal Longmire. And I did this resection with the same FDRD system as for the colon. You can see the peritoneal fat, and you can see the resection specimen, and it was R0 resected, so this patient was spared surgery. We published 4 cases. We have so far 31 cases at our center. It's a little bit more technically demanding because you have to pass this endoscope through the upper sphincter, and especially through the pylorus can be cumbersome sometimes. You have a little bit more bleeding, otherwise procedure is fine. For this indication, we are currently running a prospective randomized trial comparing it to EMR, because we have the feeling that EMR is a little bit risky, complication-prone, bleeding, secondary perforation, and we are comparing it in a multi-center European trial to this FTRD technique with a new device, this gastroduodenal FTRD system that's a little bit smaller. It brings me to the last point. This is gastric FTRD. Gastric FTRD is not a very good indication because the gastric wall is very thick. You cannot suck in a lot of tissue. It's only for the very small lesions, less than 1.5 centimeters. These lesions you don't know resect in most of the cases, but sometimes if you really want to have the histology, if the patient is young and says he doesn't want to go for follow-up, he wants to have it removed, then this technique works, and you end up with something that would, even even if you think that it's a GIST or a NET, you only end up in 30% of the cases with a correct diagnosis, but the diagnosis is made then in 100%, so it's more or less diagnostic procedures. Finally, what do we do with the big guys? With the big guys in the stomach, the GISTs above 2-3 centimeters, you could try stir, but in my point of view, this is a little bit cumbersome because of the thickness of the stomach wall. We do this. We use this device, the Gerlichs device, formerly known as the plicator, a single use, not available in the US, but you can resect these lesions with resorbable sutures and then cut it above. We published it in 2015 and received the Endoscopic Best Paper Award for it, so there are endoscopic solutions even for larger lesions in the stomach. So let me finish. I think non-exposure EFTR in the GI tract is today reality. These non-exposure techniques are effective and safe. We can use it all over the GI tract except in the esophagus. The killer indication are these non-lifting neoplasias in the colon, most of the time therapeutic, sometimes just only diagnostic because it's high risk, needs to go to surgery, and expertise in close cooperation with the surgeon is needed. Of course, there are limitations, especially the size of the lesion. So if we look at anatomically, I think in the esophagus, these subepithelial tumors, most of them are leiomyomas, most of them don't need to be removed anyhow, but if you need to remove them, stir is probably the technique to go. If you look at the stomach, you want to remove these GISTs and NETs. You run into problems diagnosing it prior to your procedures. And I think FDRD is not the way to go only for the very small ones. Stir is cumbersome because of the thickness of the wall. You have to make quite a big hole to remove the specimen. We use this non-exposure techniques using the Gerlichs. In the duodenum, so these non-lifting recurrent extrapapillary adenomas, and these NETs, I think GD FDRD is the way to go. And in the colon, as we've been speaking about it, this non-lifting adenomas and the other indications. And I think colonic FDRD is a well-established technique currently. Thank you very much for your attention.